Thank you, Remu, for that wonderful introduction. And it was so nice to have you in Prague as part of a very nice workshop on Waldenstroms. We had over 400 attendees this past year. And what was really inspiring was to see all the young people now that have been attracted to this field. We had 32 Young Investigator Award recipients, and it was really a pleasure to know that the field is in good hands. I, of course, started off with my mentor, Ken Anderson, some 30 plus years ago. And together we've been attending this meeting, I think since the inaugural meeting 22 years ago. So every year as we come here, we have more and more progress to report. And I'm very happy to tell you a lot has also happened in the Waldenstrom's field. So just sort of a synopsis of the disease. This is a lymphoplasmacytic lymphoma, largely centered in the bone marrow. But the way it inflicts its morbidity can be due either to the tumor cells growing out in the marrow and causing cytopenias, but also just keep in mind that the IgM antibody that's produced by the tumor cells can also cause hyperviscosity. It can cause many autoimmune-related problems. And we also, these days, are dealing more and more with patients having CNS disease that we call Bing-Neill syndrome. And I just want to touch upon that in just a moment. Now, traditionally, we've treated this disease by using rituximab-based therapy, typically in combination either with bendamustine or proteasome inhibitors. Cyclophosphamide combinations also play a role. And with this, we do see response rates up to 90% of patients, but keep in mind that CRs are still very elusive. Now, despite the fact that you can't get patients into CRs, what you do see, though, is meaningful progression-free survival, sometimes going out 4 to 6 years' time. But many of these therapies also have untoward effects. With rituximab, you can have this IgM flare that can affect about half of all patients. So be very careful when you're administering rituximab, particularly to people that have high IgM levels above 4,000 mg per deciliter, because you can throw them into a hyperviscosity crisis. So typically, either you plasmapheresis in advance these patients with high IgM levels, or you administer the chemotherapy without the rituximab. We've largely abandoned the use of nucleoside analogs because we do see a high rate of transformation in these patients. Bendamustine has become such a very important and prominent drug in the treatment of this disease. In North America, we tend to use 4 cycles. The Europeans tend to use 6 cycles, and we tend to use the 4 cycles because we try to avoid prolonged cytopenias. Bortezomib also is very active, but as you know, a lot of neuropathy, even more so in Waldenstrom patients than we've seen in myeloma patients, and this is because a lot of these patients do have underlying disease-related neuropathy that can be exacerbated with the use of bortezomib. Now, the bright spot in this disease came with the discovery of the MYD88 mutation. This occurred in our laboratory thanks to whole genome sequencing, and this is a key mutation. You see it in about 95 to 97% of all Waldenstrom patients. Now, in the last 10 years, we've been at work trying to translate exactly what the signaling pathway is associated with mutated MYD88, and what was very exciting to recognize as part of these efforts was that Bruton's tyrosine kinase plays a very important role in the pro-survival signaling associated with MYD88. And this, of course, prompted the development of BTK inhibitors and the approval of 2 of these BTK inhibitors, ibrutinib as well as zanubrutinib, for the treatment of Waldenstrom's macroglobulinemia. Now, when you look at all these trials collectively, what you recognize is that BTK inhibitors represent perhaps the most active single agents for the treatment of this disease. And summarizing the slide is the fact that you're going to get overall responses of 93%, you're going to see major responses in more than 80% of patients, and even VGPRs, which approach about 30%. What you're not going to see, though, is CRs. And despite this, 3/4 of the patients still remain progression-free, even with a single-agent BTK inhibitor. So I think this is indeed laudable. Now, there's also a second mutation that you should be aware of, and that's CXCR4. This also was a mutation discovered in our laboratory. It affects about 40% of all Waldenstrom patients. And the CXCR4 mutation signals in response to CXCL12. Some of you may know it as stromal-derived factor 1, which is secreted by the bone marrow stroma. Once CXCL12 comes in contact with CXCR4, in the patients that have the mutation, you don't see downregulation of the receptor, but rather you see continuous firing of pro-survival signaling. And the one thing that you'll come to recognize with CXCR4 mutated patients is these are the individuals that are coming in with high IgM levels. In fact, the hyperviscosity-related patients tend to be CXCR4 mutated. But the other thing to recognize is that this extra signaling pathway can also lead to drug resistance, particularly BTK inhibitors. And these have been all the trials that have examined the impact of CXCR4 on the outcome of patients getting BTK inhibitors. And the summary of this is as follows, that if you have a CXCR4 mutated patients, it's going to take longer to get them into a deep response. The response rates will not be as deep as what you see in somebody who's not CXCR4 mutated, and progression-free survival will be impacted. In fact, you'll see shorter progression-free survival in this patient population. Now, clinically, what does this mean and why you should be looking at CXCR4 mutations? Because the choice of BTK inhibitor is also impacted by the CXCR4 mutation status. In fact, when you look at the ASPEN trial, this was a randomized trial of patients getting ibrutinib versus zanubrutinib. Among the MYD88 mutated patients, what was seen is those patients who got zanubrutinib had better responses, even better progression-free survival at 42 months. And so this is one of the reasons why we do check for CXCR4 mutation status, because the choice of BTK inhibitor will be impacted. We also see in that tiny little fraction of patients that don't have the MYD88 mutation, they also appear to benefit with the zanubrutinib drug. Now, between these BTK inhibitors, I think you well know that there are also differences in adverse events, far less hypertension-related as well as atrial fibrillation-related complications associated with zanubrutinib, though we do see more neutropenia associated with zanubrutinib versus ibrutinib. The one slide I do want to call your attention to is this one here, because in the old days when we went about treating CNS-related disease with Waldenstrom's, being Neal syndrome, it was very difficult. We had to hospitalize patients, give them high-dose methotrexate, and even so our response rates were around 40%. This has all changed because of BTK inhibitors. We see, in fact, both the ibrutinib and zanubrutinib readily getting through the blood-brain barrier. And in fact, we're seeing, tremendous response activity, even very durable multi-year remissions because of the use of BTK inhibitors. So this has totally revolutionized the way we treat being Neal syndrome. And so, it's important to keep that in mind. Now, a very important point, that's always raised at every meeting is, knowing that BTK inhibitors are active, knowing that bendamustine and other rituximab combination therapies are active, which one should we give, particularly to our treatment-naive patients? And there was this very large study from the Mayo Clinic that was led by Jithma Abakun. It was a study that involved centers in both North America, including ours, as well as in Europe. And this was a study, though retrospective in nature, wanted to look at the outcome of patients who got bendamustine, Rituxan versus getting single-agent ibrutinib. And what we saw in this study, which was updated also in Prague at the international workshop, was that you do see deeper responses associated with bendamustine-based therapy as opposed to ibrutinib alone. But conversely, when you look at progression-free survival with a median now follow-up of 6 years and overall survival, there really isn't any difference. So if you are thinking about a BTK inhibitor versus bendamustine, rituximab, really the outcome in terms of progression-free survival and overall survival doesn't appear to be impacted with this fairly long follow-up. Though we did learn from one very important study presented in Prague, which was presented by the French group, the Philo group, is that we do need to pay attention to long-term toxicity, particularly with bendamustine. This was a bit of a surprise. This is a long-term follow-up of bendamustine Rituxan in Waldenstrom patients who received it this combination as treatment-naive patients. And what we saw was from this study, a fair amount of secondary malignancies, particularly myelodysplasia, converting over to acute leukemia. So for our younger patients, we tend to be avoidant of using alkylator-based therapy. And I think this study was very much instructive in that regard. Now, as our patients are growing older with us on these BTK inhibitors, we are seeing, resistance emerging. And for this reason, there's been a lot of now concern around how we manage the patients that have become resistant to covalent BTK inhibitors. And by covalent, I mean those BTK inhibitors that bind to BTK cis481, because most of these drugs, ibrutinib, zanubrutinib, acalabrutinib, they all bind to this same site on the BTK protein. So pirtobrutinib has now emerged as a very new and exciting drug for the treatment of those patients who have become resistant to covalent BTK inhibitors. And in fact, we saw a very nice update presented by Leah Palumba at the workshop in Prague. And in fact, you can see, almost 80% of the patients attaining a response with pirtobrutinib. And in fact, the progression-free survival in these patients is also very laudable. We've had patients who have progressed on a covalent BTK inhibitor who have been on it for almost a decade, and then they go back on pirtobrutinib, and you see, in fact, they almost go back to the same level of response they had with the covalent BTK inhibitor. So we're very excited about the use of pirtobrutinib in this patient population. Venetoclax also is very important. Waldenstrom's is also very BCL2 dependent. And in fact, when you look at the data with single-agent venetoclax, you see 80% major response rate, even among patients who have been treated with a BTK inhibitor previously. They can be salvaged almost to the same level as somebody who might be BTK inhibitor naive. And CXCR4 doesn't appear to play as big of a role with venetoclax as we see with BTK inhibitors. And you can, in fact, see from the study alone where patients were given 2 years of venetoclax, even a median progression survival that was just shy of 3 years' time. Now, what does the near future hold for the treatment of Waldenstrom's? And these are the exciting slides I want to share with you. There's been a lot of progress, and a lot of this progress was reported in Prague. The Brahms study is one that got us all excited, and this is now combining BTK inhibitors with bendamustine rituximab for treatment-naive patients. And in the Brahms study, which was from the Canadians, they used acalabrutinib in combination with bendamustine rituximab. And Neil Berenstein presented this very nice study where patients only got 1 year of acalabrutinib along with 6 cycles of bendamustine rituximab. And what was recognized here is everyone had a major response. Almost a quarter of the patients got into MRD, which we haven't seen previously. This was largely independent of CXCR4. And as you can see, the progression-free survival is excellent, though the follow-up here remains fairly short. The combination of pirtobrutinib with venetoclax may also emerge as a new standard for treating relapsed refractory patients. This is from a study at our institution, combining pirtobrutinib with venetoclax, and in fact recognizing almost 90% of the patients getting into a major response with good progression-free survival curves so far, though again, this is a fairly early study. Now, just to get you excited, there are some new drugs which are showing strong signals in Waldenstrom's. The BGB 16673 drug, this is a PROTAC or degrader, which binds to BTK at sites that appear to be different from where you see the covalent as well as non-covalent BTK inhibitors binding. And what this drug actually does is it drags Bruton's tyrosine kinase to the proteasome for destruction. So you're actually destroying BTK as opposed to inhibiting it. And some of the best data that has now been generated with this drug is, in fact, in Waldenström's macroglobulinemia, where you're seeing almost 3/4 of heavily pretreated patients showing a major response. But I think for me, what's even more exciting is when you look at all the genomic subtypes, be it MYD88, CXCR4, TP53, but also BTK itself across many different BTK mutations that have been acquired because of covalent and non-covalent prior therapy, you're seeing high levels of response. And even those VGPRs that are so laudable, we're getting to those, even in patients that are carrying the CYS481 mutations, as well as those mutations associated with non-covalent BTK inhibitors. So this, I think, is going to emerge as a very important new drug for the treatment of Waldenstrom's. The other drug to get excited about is sonrotoclax. This is a novel BCL2 inhibitor. This drug appears to overcome even the G101V mutation associated with venetoclax resistance, and the ability to actually titrate this drug up is much easier than giving venetoclax. And here, too, one of the best signals that's been seen with this drug is, in fact, in Waldenstrom's macroglobulinemia. So, lots of progress. More to be reported. Our next workshop will be in October of 2026. This one will be held in sunny Palm Springs, California. And we look forward to welcoming many of you, including Remu, back for this very exciting workshop with more updates to come. And with that, I'll conclude. And thank you so much for your kind attention.